Pennsylvania health system and moved up in administration, eventually became head of Pennsylvania Hospital. I was the CEO there. And then I was also the chief of operations at the larger hospital at the University of Pennsylvania. I left there and I became the CEO of our health system, which is a 3-hospital system in Philadelphia and a very large outpatient footprint. And over 6 years after that, we merged it into Thomas Jefferson University. And I was the chief integration officer, and my role was to bring the 17 hospitals that we had merged with into some semblance of an integrated healthcare system. And just to give you an idea, we were really starting everything from scratch because there was no common, as you could imagine, HR, IT. So all the back office corporate departments had to be formed, including finance, putting together a CBO, doing revenue cycle, and then moving that forward. But the biggest thing that was the challenge, which is always a challenge in any organization and any integration, was developing a common culture. And still to this day, they are really struggling with that. And it is the thing that I think is most apparent in any type of these deals that go forward and why they often fail. After that, I left and I worked for Prospect Health System and did a lot of work with them on the venture capitalist side, as well as managing the East Coast for them. So I had 17 hospitals, New Jersey, Connecticut, Rhode Island, Pennsylvania, and was responsible for everything there. So I left there and was doing consulting work. Most recently, I was at Atlantic Care for the last 8 months. So as you can see, I have a pretty varied background. I was also on the education side. I have a doctorate in education, an MBA, a master's in nursing, and a master's in education. So one of the things that Penn did a really great job with is they allowed us to go to school, and they paid for all that for me. So it was, a wonderful opportunity for professional growth and mentor. So I'm happy to take any questions. That's sort of my career in a snapshot, and anything that people might be of interest in knowing about in some of the roles that I've had and how I might be able to help you as you're going down your journey in your professional development.
Thanks, Kate. It's very, very generous of you, and what an incredible career. So congratulations. I'll start off with some questions as we normally do. So what was it like every day managing 17 hospitals? Well, what does that job look and feel like on a normal day?
That's a great question. I mean, certainly people were always kind and cordial, but what it felt like is that you needed to, and I think this is the biggest lesson I learned from that. It's influence. And oftentimes in our careers, because there exists hierarchy in many organizations, we get things done because we are the boss over a particular issue, item, department. But when you had 17 hospitals, and you can just imagine the various groups that you were trying to satisfy, from the physicians to the CEO of those hospitals to their boards, that what you had to do is really learn how to influence. And it's a different skill set than management or even leadership. So influence took time, and it was something that I didn't discover right away. So you can imagine that you could see some failures because I was used to being the CEO. And when you're the CEO, and normally if you tell people this is where we're going or this is what we should do, and I believe in a collaborative leadership style, but even with that, when you're the CEO, people generally follow you. When I was the chief integration officer, they could choose not to if they didn't want to. And even though I reported directly to the CEO of the hospital, Steve Glasgow, there were those who shook their head and said yes, and then went off and did what they want. So the biggest thing, and my day-to-day challenge and my day-to-day learning, was really how to learn to influence people in the appropriate way to get them moving in your direction, but having them think it was all their own idea.
And was these 17 hospitals, did they fall within a larger family of hospitals across the Jefferson Health system, or this was the entire universe at the time?
So it was the entire universe at the time, but academic medical centers are really different than community hospitals, because in academic medical centers, what you have is little fiefdoms, because every chair is a leader of their department. So you had a lot of community hospitals. The hospitals, if you're, for those of you who were in the Philadelphia area, it was Abington, Aria, Einstein just recently joined with them, and many of those hospitals came with multiple hospitals. So when I had Aria, I had 3, Abington had 2, Einstein had 4. So and then there was several hospitals in New Jersey, which had been the Kennedy healthcare system. All very different cultures, very different ways of looking at things, different product lines that they thought they were the best in. And it was interesting. I was just at a conference down in Key West on a board that I am on, that conference used to work at Abington Hospital, and Abington was part of the conglomerate in Jefferson. And her comment to me, she was disappointed at the outcomes of their merger, because she thought that they were going to get all these things and everybody was going to be looking to Abington to say, oh, how do you do this? Because in their mind, Abington did it the best. And when you go into a large system like that, what you're going to fall under is the umbrella of the parent. And the parent was Jefferson. And the parent really could have cared less what Abington thought. So that was a learning, when you go back to influence, is that you've got all these people who come into this with different beliefs of what it's going to look like. And you've got to bring it to a singular belief. So to your question, people came in as somewhat large entities in different geography, with serving different populations, some very high socioeconomic, some low. And the chairs, as I was saying, in the parent at Jefferson had a lot of power in how things were going to go.
What was the primary benefit that you were able, or tried at least, to sell to all these different constituents attached to the concept of integration? What did you think was most realistic and most impactful in terms of benefits to them?
So it was pretty early on that I realized, and I mentioned it when we first started talking about the culture. And in that, I tried to impact to them, because everything else is tactical. To create a CBO is a tactical thing. To put HR policies in place, again, it's tactical. It's trying to get people to understand that they're in a new entity. So what we did, and it's funny, they're still using it today. We created this term, and it was One Jefferson, and we put it on everything. And we really started from branding, and it's marketing, really, and internal marketing to people, to get them to feel the pride of being part of Jefferson, and that to try to preserve their individual culture, but to understand that they're part of a larger culture. Because it wasn't until you saw some movement in that you got real cooperation. Because until people understood that they were no longer a standalone organization, that they were now part of a bigger whole, that they needed to behave differently because of that, that sounds maybe simplistic to people, but to me, that was the biggest thing that we were really bringing together, because everything else, we had a lot of help. At one point, we did a very, very large contract with GE Healthcare, and there were probably 150 consultants, and they're working with me. Jefferson was a big organization with consultants. They had lots of consultants in and out. But we were doing a lot of the work, the tactical work, and then also working on the cultural work. But one of the things they brought, and this is probably 7 or 8 years ago, was really focusing on AI in staffing. In healthcare, as you all know, in particular areas such as the operating room, if you're a trauma center, labor and delivery in the ER, it's unpredictable volume and it makes it difficult to staff to it. So we were using AI and machine learning, way back then to try to, you know, do some smoothing and ensure that you had the appropriate staffing. So, that was a big help. But going back to your specific question, it's really about changing the culture. It's, they say when you're doing mergers, the culture eats innovation every time, or culture can eat the whole process of the merger. And it is absolutely true.
So we see hospitals becoming health systems, hospitals joining pre-existing health systems expanding across state lines, health systems expanding across the entire country. And we see the demise of individual hospitals of all kinds, academic, community, for-profit, non-profit, due to their lack of size. And we also witness, especially most recently, the FTC and state level regulators becoming increasingly concerned about large health systems becoming monopolistic in certain markets. And so how do you balance those two concepts? Because they seem to be in contradiction with each other. On the one hand, there's an enormous momentum to scale and aggregate as a health system in order to survive. Right? Most hospitals are struggling in terms of profit margins, are struggling in terms of their budgets, are struggling in terms of their manpower, their labor costs, and yet they're not really supposed to get too large. What are your thoughts on the subject? Do you see clear and obvious benefits to aggregating hospitals? Do you think it's a net positive? What's been your experience of it?
So I would say that most mergers, they actually don't do it correctly, because just as I was describing to you, they don't become one entity. I think if you go out to, and I know they're all on strike out there now, and interestingly to me, they're paid very well out there, but it's Kaiser Permanente I'm talking about. They've done fairly well at integrating the hospitals that they have brought together, because scalability only helps you if in fact you get to a place where you're not having duplication of services. And it is really hard for organizations to do that. And what do I mean? If you go back to the Jefferson example, in that system, when they brought all of that together, you had several of the hospitals that were doing open heart surgery. Now, geographically, they were maybe 10 miles from each other. What needed to happen, and still hasn't happened because of political reasons, is you should get down to one program. It should be housed at one of the organizations, and that is where all the resources should be put. But nobody wants that to happen, because I think part of the issue is how the finances are set up. So the first thing into your question is that when you do the mergers, they need to be set up correctly so that you're not disincentivizing people not to make the right decisions. In reality, when you look at scalability and you look at the research that is done now, it's not truly longitudinal, because this has only been going on in healthcare for maybe the past 10 years, is that it hasn't really decreased the total cost of care. And if you're going to do merger, whatever the product that you have, and it's interesting, I was telling you a minute ago, I was at this board meeting, all the discussion in banking now is about scalability, that you have to get to $1 billion. When we merged ARIA, that was the conversation. If you could just be $1 billion, you're going to be okay. Well, that's not true, because now you've got these organizations that, Jefferson, again, as an example, and what I'm telling you is not inside secrets. I mean, you could go out and find this information out yourself. So I just want everybody to be aware that I'm not, breaching confidentiality here. But it's a $5 billion company, and they haven't made margin since they did these mergers. And many of those hospitals were making margin beforehand. So, in my estimation, scalability is really not the answer. If you go forward with scalability, what you need to do is then become efficient and effective. And if you don't do those two things and you just bring whatever the industry is together, you just have a lot of pieces and no coordination.
It feels like it's not a
So
it's not a panacea, is it
right.
sounds like is what I'm hearing. Whereas, and we see this in the outpatient world as well. The question, the overly simplified business philosophy of as long as I'm growing, I'm fine, and it doesn't really matter how many assets I'm acquiring. There's no such thing as acquiring too many. It doesn't matter what the diversity is amongst the assets. There's no such thing as too much diversity. And our experience of that is that that's far too simplistic, and that the reality of scaling any business is far more difficult than that. And us humans tend to ignore diseconomies of scale, which are just as real as economies of scale. Is that fair?
No, I think you're absolutely correct. And I think the FTC has reason to be concerned, not only in healthcare, but education is doing this now. As I said, banking. And when you look at that, that when you take any very large organization, whatever the industry, because anything can fail, now it's not a singular community hospital that's serving, a geography of maybe 25 miles. It could be a geography over multiple states. And if it fails, you've left a tremendous void. So I think we need to ensure that if we're and the people are not going to stop merging because they do think it's a panacea in this era that we're living in now. But I think that what we need to understand and learn from the lessons of why many of these mergers don't achieve the outcomes that we've been looking for.
Right. I agree with you. Couldn't agree with you more. Shifting a little bit to the left, the other large, big objects of change, think of them as planetary objects of change that have been circling around us. I'm interested in your views from a health system executive perspective, and also knowing that you stay so close to so many other health system leaders. So I'm thinking of value-based care, I'm thinking of virtual care, and I'm thinking of technology, automation, you mentioned AI, and I'm also thinking about the movement, the migration of in-care to outpatient care, ambulatory care over the past 20 years. For those large planetary objects, which of them has been the greatest source of opportunity for health systems? Which of them has been, or will be, which of them has been and will be the greatest threat? And which do most health system executives currently ignore altogether because there's poor fit for them in the way that they're structured? So which of those big changes are they really heavily invested in and generating great results from?
So I think if you start with value-based care, when that hit, when that conceptually came out, and a lot of it was developed from CMS, it became something that quite many organizations, CEOs adapted. And I will tell you, as a clinician, I think value-based care is really where we should be going. However, it goes back to the same thing when I was saying why some mergers fail. It was disincentivized because payment models never caught up with the concept of how you were going to be delivering care. And we saw this many years ago when there was the rise of HMOs, and they were not adopted by many of the American population, just because they didn't want to have to get a referral source. So I think value-based care is important. I think a lot of CEOs still think it is, but they're holding on to the fee-for-service model as much as they can, and they're not going to let it go. And in actuality, the organizations who didn't do anything in value-based care did far better and have better margins today than those who tried to do it. So from a strictly financial perspective, I think that value-based care is sort of teetering. But from a clinical perspective, it is the right way. There is, when you talk about outpatient and remote patient monitoring, interestingly, there is some data that is coming out, and it is saying that value-based care and all of this effort to try to improve the care of the patient in the home has not been as effective in decreasing the total cost of care, because that was really the impetus behind it, as we had thought it was going to, which I found interesting, because I think if you could do it properly, it absolutely should do that. What is the big problem? It's compliance. And part of it is when you set it up that we're not investing enough money into some of the boots on the ground people to be able to have this effectively operationalized. So, hospitals, and you discussed it in your opening statement, is that they're really struggling financially, and many of them say, okay, what is my biggest cost? It's labor. It's usually 60 to 70% of your expense portfolio. So let me eliminate some labor, because that's an easy way to try to get that cost down. And who do they eliminate? People like your care coordinators and your social workers. You see lots of that happening. So I think that's a very big positive, and I think remote patient monitoring is the way to go. But again, it's this misalignment of how people get paid for things. Medicaid does pay for it now, but a lot of the other insurers do not. So now we're having a two-tiered system where you get Medicare patients on it, but everybody else, they're not, going to have that availed to them. So to your question, I think everything, the big global things that are on the horizon or have been here for a while all have utility, but we've got to look at how it's set up. And it all comes down to, somebody told me early on in my career, and this is true, follow the dollar. And if we don't do it correctly, and that someone can't make money from whether it's a good thing for the patient population or not, it's not going to take hold. One of the things that you did mention, the final, and then certainly turn it back over to you, is around AI and some of the work that I am seeing out there. I had a lot of opportunity to investigate this in a previous role that I was just in. And I think that, and this is true for the entire labor market, that when the cost of labor becomes so high and that you're having double-digit increases every year, they're going to figure out how to do a lot of this through technology. And you're already seeing, and I was speaking to somebody in the military yesterday, and he was telling me, which ties into your question, that there is a new aircraft carrier that was just developed by the United States Navy. And it is if you would stand it upright, it would be the size of the large, like the Empire State Building. It's very, very big. And it used to require 24,000 people, naval people, to operate it. This new one requires 1,400. And so it's the point that I'm making, and you're seeing this in healthcare, you're seeing this in every industry, it's driving technology to figure out how to do a lot of this without people. So that doesn't mean that we're going to not have people in any role, obviously, but the jobs are going to be very different. And I think that we're on the precipice here, that many of the traditional roles that people have played in healthcare are going to be upended because of technology. So to your specific question, I think that is going to be the one that is going to be the biggest disruptor, and that what we need to watch, because I do believe that it's going to have significant effect on particularly the labor market.
You've seen automation tends to work well in a very narrow scope. As soon as it's introduced into a very complicated environment, and I would say a hospital on its own offers so many different services, and healthcare has a lot of inherent complication to it. This concept of unintended consequences and complexity rears its head time and time again. I'm thinking of, I'll use an analogy to match your analogy. You know, the NASA space program and the construction of satellites has gotten far more complicated over the last 50, 70 years. There's many more parts today in a rocket than there was, 50 years ago. And that complexity creates error. They still blow up, they still fail, and it creates a lot of need for a lot of technical expertise. There's hundreds and hundreds of companies involved in the construction of any one rocket through outsourcing. And so it's interesting when we talk about these large changes, virtual care, value-based care, outpatient. Some of them are more experiments than others, and some of them create more unintended consequences than others. And things that are experimental, some hospitals can participate, others can't. Some succeed, others don't. They're not necessarily as one-dimensional as pure automation would like to think so. So it's just interesting to observe. Other big trends out there, and I'm wondering how the average health system executive, if there is such a thing, feels about these trends. Might include vertical integration, absolute integration between payers, health systems, and providers, and then horizontal integration. So now introducing large big box retailers, both digital and brick and mortar traditional, into the health system equation. How do health system executives react to those big changes? Just because a change is big doesn't mean that it's sustainable. Right? We've seen waves of new entrants into certain marketplaces that come and go over time. Do they view payer ownership of large provider groups? Best example, United, Optum. Do they view retailing groups' ownership of health system assets as sustainable, the path of the future, or do they view it as a temporary wave?
So there's a great deal of concern around some of the new entrants. The big box, Amazon, United being in healthcare, they bought Optum. So many of the hospitals had all their data in Optum, and now you have United owning it, even though they say there's a huge firewall and that they're not going to transgress that. So there definitely is concern. And I think, when I speak to my colleagues, some are more concerned than others. Others believe because they have, large scale that they can compete. But in reality, I think it would be hard to compete against, somebody like an Amazon or a United if they really wanted to go all in. I think that what people are forgetting is this, and this is where I believe scale has a lot of potential, is the physician. Because no one comes to a hospital to see an administrator or to see your insurance company. The relationship is with the physician. And the only industry where the source of revenue is often totally independent of the source of the providing of that service is healthcare. Because physicians are often independent. Now you're seeing some movement towards physicians becoming employed, but that often, depending again how it's set up, is not working that well because you're seeing a decrease in productivity. So you see, a physician that was producing X amount of RVUs and in employment now it's cut in half. They're taking an hour for lunch and all these things, which you would say, of course, people deserve lunch, but that has been the unintended consequence, to use your words, around that. So then the other thing I think that we're seeing is that many physicians are joining into these mega groups. You've got urology is doing neuroscience, ortho. And then some of the physicians, notably primary care, are joining with other organizations like the Uniteds of the world. It's going to be wherever the physician, where all this movement in the market ends up. This is what I think is the most important thing a hospital can do, is to really value their physicians, have them be at the table, make sure they're part of decision making, and to be seen as true partners. Because if they don't start doing that, and I think oftentimes hospital administrators, I don't think, I know, they see the physician as a commodity. And that is what has created this disassociation. And so I really believe that that is the piece that we have to watch, and that is the piece that is most pivotal here. And then just one other aside with that, my other large concern, and I've noted this over the last several years, and you talked about the complexity in healthcare, which is absolutely true, is boards. So many organizations have boards that have, they might be the local grocer or the, person who was on their foundation. They have no concept of really how to run these multiple billion-dollar companies that have a lot of complexity to them. So it's very concerning to me that the governance piece, which is extremely important, is, I don't think, up to par in most organizations. And then at the same time, you've got hospital failure to understand the importance of the physician.
I'm reminded, listening to this answer, of other examples that have come and gone. Standard Oil used to have, that's John D. Rockefeller's oil company, used to have 90% market share of the oil industry.
Right.
And I know at the time, the one person in this country who thought that made perfect sense was John D. Rockefeller. So, the nature of companies, whether it's United or Standard Oil, is to grow. But these things are rarely sustainable as the decades pass. So it's just interesting to see how things will evolve. I want to open the forum up to the rest of our audience and invite, as we always do, anyone to ask Kate any question.
Hey, Roy, this is Mark. I have a question.
Go ahead.
Kate, really enjoyed your talk, especially the part about the doctor-patient relationship. I put in the chat that I think that's the most underrated value in the whole ecosystem. And when they learn how to use that, it'll be a game changer. But part of being independent is being disorganized. So it does take some leadership. But my question is, the hospital practice world, where do you see that going as opposed to the independent practice world? And how do they relate in the same sort of hospital systems that we have?
So I think it's interesting here on the East Coast. I think you're going to continue to see the hospital practice world grow. That there is this thought that if we own the physician, whether it's through a big practice or in some way, that we will be able to be successful. In California, as you are probably aware, you're not allowed to employ physicians there. And so I think you're going to continue to see large growth in physician practice plans. And then the relationship with them is going to be very important in those states where you have that. So I do believe, and I agree with you, I think that this is the area that we really need to focus on. You're going to see it be different based on different geography. But I think that the most important thing, when you think about the physicians, they have been socialized through their entire career, and rightfully so, because they have to make these kinds of decisions to be independent thinkers and to be very decisive in what they do. And yet they're not treated like that within the ecosystem. And I think why you're starting to, not starting, it's been, a little while, but the physician burnout phenomenon, and that they're dissatisfied with their role and they're looking to, go into other venues. And there is statistic that says that if their children or someone would ask them, they would say, don't ever go into healthcare. So that in and of itself is problematic. And, it goes back to your point, but I think that this is where a huge growth opportunity is going to be in the physician side, and the organization that helps to get it right and to
Thank you.
Great question.
Kate, building on that question, are you seeing an increase? Should we expect an increase in outreach from health systems to form strategic partnerships with other health groups in the name of coordinated care, in the name of optimal outcomes for health systems and the challenges that they face today? Part of this is sort of opportunity seeking. Part of it is risk mitigation, dealing with expensive labor forces, dealing with things that haven't worked. Net, more strategic partnerships, because I know in the past it hasn't been the easiest working with large administrative health systems.
I think it depends on how innovative the CEO is and how much they can convince their board the importance of that. You're seeing, Cedar Sinai is one that they have large innovation centers. Penn has Penn Innovation, and that they're working very closely with startups as well as, with current companies to have more of a vertical integration. So not just horizontal, but to do vertical as well. I don't think you see that everywhere. Part of going back to scalability, if you're large enough, you can afford to do that. If you're a community hospital, it's going to be unlikely that you could have that as part of your agenda. That's because of the cost. And at the same time, you don't have the bandwidth. You don't have the capability of hiring individuals who can make that their full-time role. So, I think it's extremely important. There are so many interesting tech companies that are out there that are going to change the face of healthcare. When you look at what's happening in the behavioral health space, which is extremely important, Andy Savage, who was the previous head of CMS a couple of heads ago, he has started a company that is somewhat like that show that is the one about that you come and present to the group of people. What's that called? Not Millionaire, but anyhow, Shark Tank. And so he's done something like that with startups, and he has brought organizations together. And I know when I was at Jefferson, I was part of that group, and you would go and look at, various people would demonstrate, what they had, and you could choose to become a beta site for them or not. But that kind of thing is not going to be available, as I said, because, you have to have enough scale to be able to do it. But I think it's going to be really important, as we move faster and faster in the development of ways to look at healthcare differently, look at the world differently. I think AI is going to have a significant change in the way we do things over the next 5 years that we probably can't even contemplate today. And it will definitely be seen in healthcare as well. And, a while back, I had mentioned that I thought it was going to displace some people. And I don't want to leave anybody with the thought that I'm saying that I don't think we're going to have doctors and nurses. It will be things like your registrar. You're not going to need a person to do that. I actually had blood drawn the other day at one of the local hospitals. And when I went in there, everything was totally automated. There used to be 20 people that were registering people, and there was one person there now. And all that person did is ask you if you were able to get through the sequence of things. So it's those types of changes, and you take that registrar person. How do we re-educate you? That's another big thing that I think that we need to think about in healthcare. I'm not suggesting we don't have you anymore. It's how do we teach you to now survive and thrive in this new world.
Hey, maybe on that topic of surviving and thriving in the new world, the question on sort of incentive structures within the hospital system. You've talked a lot about the need for change, new competition sources, and new ways to compete. What you also mentioned about sort of the challenges at the board level and the quality of the board in certain cases. What is the catalyst for innovation at the hospitals, oftentimes that are nonprofit? You've worked across many different types of hospitals, some public, some for-profit, some nonprofit, some large, some smaller. Can you just talk us through sort of that dynamic as a CEO, that dynamic as a board, and that dynamic at different types of hospitals with different ownership structures?
So I would say the for-profits, one of the things they do really well is the data. And they manage and drive change through data, which I believe is really important. And I think the not-for-profits could certainly learn from them. One of the biggest advantages that healthcare has in general is the amount of data that we have. And if you look, as an example, American Airlines, when COVID hit, they monetized their data. Their company at that point was valued at I don't know, $20 million. And the data that they had was valued at $50 million. And it was how they were able to hedge through what was going on during the pandemic and people not flying. Healthcare has far more data than that, and yet we have not learned how to monetize it. So I think that when you think about innovation, it goes back to who are the people running it. Not everybody believes in it. There are some people, it's like, let's go back and just keep doing things the way we've always done them. I mean, when you look at the staffing model in the hospital, it's a nurse, it's a tech, it's a doctor. Well, what is the biggest rise that we've had over the past 10 years? It's mental health problems. And, they don't know how to deal with that on a med surge unit. Why don't we have social workers up there? Why do we just staff the way we've always staffed it? It's because we're not innovative. We tend as an industry in healthcare to be very conservative, to be able to not look outside of the box, to say, well, we'll just keep doing this way because we've had success 10 years ago. So I think that the leader of today needs to be really different, and you need to be open to different ways of doing things. And that's why I believe that the board is so important here, because you can't just have them, agreeing with everything the CEO says. There has to be pushback. There has to be differentiation at the table. I think, not having all the same, there often tends to be like bankers and lawyers. You've got to have a lot of diversity of thought, and you don't see that there. So in order to get to what you're talking about, Jason, I think there needs to be changes. And what will happen as people keep merging, you will see, hopefully, people who become innovative and continue to go down that road. But those who don't might not be in existence any longer, or they might be merged into something else. So I think it's going to be really important. That's got to be part of the toolbox of the leader. And in a lot of places, I will tell you, it is not. I think that I will tell you, when I was at Jefferson, they were hugely innovative, but the CFO didn't want to see it happen. So that's the other thing. How do you bring your executive team together to have everybody be on board? Because that's not an easy thing to do.
Any final questions for Kate? Kate, I want to thank you very much for spending this morning with us. It was very educational and very helpful, and really appreciate it. Thank you.
I appreciate being able to share some of this. Great questions. And, I hope it was of interest to you.
Thank you so much.
Thank you. Everybody have a great day.